We present a 90-year-old retired brigadier from Chennai, living alone, who presented to us with 3 years history of insidious onset, slowly progressive cognitive impairment. The memory problems were detected by the granddaughter at Boston Logan International Airport, and she was seeing him off the company. The following were his comorbidities: seizures, syncope, CCF with low ejection fraction of 35% and concussion fracture of L1 and L2, which were detected as the process of rehabilitation went on. As is the want in TRIMED, he underwent a 360-degree assessment with us and was diagnosed to have Alzheimer's disease and started on appropriate medication and integrated medical treatment. I'm going to describe the team in each of our centers. At the helm of affairs is the allopathic doctor, the family physician, who was ably guided and assisted by the naturopathic and yoga physician, the Ayurvedic physician, the nutritionist, psychologist, counselor, physiotherapist, and therapy assistants who deliver therapy to our clients under the supervision of the medical team. This is the integrated treatment he actually received. He first started with center-based therapy, which lasted from 36 months to 24 months. This time duration is from the index visit. Center plus home from 24 months to 18 months. And he received home-based care for the last 18 months until he passed on. The components of treatment were modified as the illness progressed. He more or less received Ayurveda, naturopathy, physiotherapy, and psychological work. Towards the end of his life, towards the last 6 months, he was given gentle therapies to improve quality of life. These were the emerging challenges of the comorbidities. Transition to home-based care for a year and a half. Recurrent urinary tract infections, syncopal episodes, seizures, falls, cardiac insufficiency, compression fracture of the spine, L1, L2. This was treated conservatively in the hospital. Gait imbalance, increasing walking difficulty, restriction of physical activities. As a result of all this, he became housebound and unhappy, but at no point did he lose his social niceties. Social niceties were preserved until he choked on his food and had a seizure, and he never really recovered of it. What not to fix is what we're going to be talking about today. I'm going to just quote this. So the fork on the road of life systems come and leave it at that for the audience to ponder about. He was inching towards the end of life care when the frequency of these ictal episodes that were first detected around 14 months ago started increasing. In the last 6 months, with recurrent ictal episodes spaced days to weeks. Seizures. Yeah, the frequency of seizures, sometimes it was difficult to actually make out whether it was a seizure or a syncope, but it was a mixture of both sometimes. Continued to increase in the last 6 months, with recurrent episodes spaced days to weeks apart, necessitating frequent consultations with the cardiologist and continuous monitoring with the TRIMED team, with frequent visits by the physician, comprehensive iron therapy, and monitoring of progress during weekly pre-mental. The family was educated, my apologies. The family was educated as to the progression of the illness and the declining quality of life. This was done in the right earnest over multiple sessions, over the telephone, by mail, and whenever the family had come down to India. The team was always available for any emergent problems. Sudden downside, the daughter was eagerly looking forward for him to come down to India to spend, the granddaughter was eagerly looking forward to come down to India from Boston to spend the day with Tata on his 93rd birthday. And a whole lot of preparations were made for this. Before close to his 93rd birthday, close to his 93rd birthday.
For all of us to think about who decides. And third, Dr. Srivatsa talked about the DNR. It's a common practice in the intensive care unit. Do not resuscitate orders. These are a daily order. It's not a one-time order. It is decided mutually between the treating doctors and the family that there is no point intubating and ventilating this person, or there is no point resuscitating them in case they go off while on the ventilator, because things are too far gone. It is a very challenging decision to make, and it has to be reviewed every day. I've had a patient, an elderly man, son of a doctor, who told me, "Doctor, promise me no tubes if I ever need it." I said, "Fine, I promise you no tubes." And this was after getting admitted to the respiratory infection in hospital. And then the day after, when I asked him, "Sir, you said to me no tubes. Are you certain that that order stands, that you want me to continue with no tubes?" He is completely alert, a fully fit 83-year-old gentleman, except for the respiratory infection. So when I asked him the question, he said, "Doctor, I'm having second thoughts. I want to live. I'm not so sure that I don't want tubes." And so I changed the order that evening in my evening round. That night he arrested when he was intubated and ventilated. And I could sense that he regretted that change of heart. But we are humans, we have changes of heart. And so how do you walk through all these aspects when you're dealing with an older person is another thing that we may want to talk about. So I'll pause there. Thank you, Dr. Srivatsa. I have great pleasure in introducing Dr. Neeraj Agrawal, who is our keynote speaker today. He's an MD in psychiatry from the All India Institute of Medical Sciences and trained extensively in the UK. He is now a consultant neuropsychiatrist and honorary senior lecturer in St. George's Hospital in London. And he is also, I'm very happy to say, like many Indians abroad, doing so well that he is the editor of the Oxford textbook of neuropsychiatry. So please welcome him to our midst and look forward to hearing from Dr.
Thank you, Krish. Thank you for asking me to come over. It's really an honor to come here and talk in front of all of you. We can keep people alive for years and years, and they may not have meaningful life. And then the other end of the spectrum, where we are all a lot more better educated, we can think through all the issues, and we generally look for more autonomy. We want to decide for ourselves what we want to happen in the future. But on the other end of the spectrum, there is increasing restlessness in society. We have on-the-tap mentality generally. If we want something, we want it now. And gradually, improvement in society and advancement technology has allowed us, if we want something, we can get it now. We get so used to it that when we are not able to do certain things, it becomes very frustrating and it has emotional impact. And then comes the societal change. Again, the case very well illustrated. Society has changed, families are not the way they used to be, people can be far away, and it all brings in its own challenges. So I'm going to talk about a case which I come across. It's very similar. I won't go into details of the case, but this highlighted the problem to me. So this was a case where in our neurosciences center, one of my consultant neurology colleagues came and spoke to me. I said, "I'm sending you, I want you to see a patient who wants to go to Dignitas." And Dignitas I'm going to talk about in a minute, but it's a facility in Switzerland where people can go and end their life when they choose to. And the neurology colleague was concerned, is this patient, does this patient have depression, they are suicidal, or do they have capacity or not, and what can we do? And essentially, they were feeling rather worried themselves. They didn't know what to do. So this patient I saw, a 47-year-old lady who was a very senior psychologist in one of the London hospitals, very well-known figure. She was head of psychology. She retired in 2009 because she had secondary progressive MS. which started in her mid-20s, but she was quite well, achieved quite well over the years, but became increasingly unwell. By 2009, she was wheelchair bound. She had a partner for a long time. She was not married, but it was as good as marriage. They lived together, they had children, and he was also a very senior psychologist, and they had 2 children who were teenagers. And when I saw her, essentially, this is a lady who doesn't have any psychiatric condition. She's not depressed. She has mental capacity. She looked in my eyes, sat in front of me on a wheelchair and said, "Dr. Agarwal, this is my life. This is what I want to do. I want to Dignitas. And what I want you to do is to do a letter to say I'm not depressed, because this is the recommendation of Dignitas, that they want a letter from a psychiatrist saying this person is not depressed." So I said, okay, I hear that. And I said, well, look, I clearly don't think you are depressed. But then I got worried, because if I give that letter to this lady, she goes, she ends her life in Dignitas. Could legally I be responsible? Could I be seen as somebody who has assisted her in her suicide? Because that is still a crime in the UK. And we'll talk about legal and ethical issues in a minute. So I went on and talked to lots of people, discussed with some colleagues. Everybody was unsure. Went to a couple of other people. So I went to our medical indemnity advisors.
Emotional and logical conclusion before going to legal. Considering the rule of law and its implementation here in India, we have to value the plus and minuses of this complicated euthanasia. So which one outweighs, in your opinion, whether to relieve the suffering to the individual or allowing the field to be a ground for people to play with illegally?
It's a very complicated question, but it's a very, very good question. I think it is going to be really very, very different in every case. I think the difficulty in creating any new law and any straightforward kind of paragraph to advise anybody is going to be always extremely complicated in this case, because every individual situation is so different. Because there can be vested interest, whether it's from family or other people, there can be vested interest. And we don't want that to become a problem, and we discussed all the ethical issues as well. So I think there is always going to be that balance between autonomy, stopping the suffering, versus all the risks, and how do we balance that? And I guess different societies would come to different decisions. Like I gave examples of Netherlands or Belgium or a number of United States states. So United States as one country, there are only, I think, 4 or 5 states at the moment, 5 states, I think, out of 50, which agree with this, whereas other 45 don't. And I think that probably would be the situation. Every society would be divided on this.